meeting is being recorded, and the recording will be posted on the committee's webpage shortly after the meeting. And for everyone's reference, today's agenda can be found under the first tab in the materials. And as a reminder, once more, if you're not a member of the committee, please do turn off your camera. And Pam McEwen, FTAC liaison to the Universal Healthcare Commission, will now call the meeting to order. Pam?
Yeah, thank you. Thank you, Angela. According to my computer, it is just about 3:02 p.m. And I want to welcome everybody here. For FTAC members, welcome to our second official meeting. And to everyone who's joining us today, thank you so much for being here. We appreciate the participation. We begin with a land acknowledgement at our meetings. And I am in Seattle right now, so I'm going to, I want to just acknowledge that the original inhabitants of Seattle were the Duwamish people. They have been here inhabiting these lands for 8,000 to 10,000 years and are not currently a federally recognized tribe. There's a long story to that, but has to do with tribes being kind of sent away to join other tribal reservations. I want to give an overview of the agenda. And I want to note as I do this, first, as we look at this agenda, I want to thank the staff and all the work behind the scenes work that goes into preparing this. And I want to encourage questions all the way down the line through this agenda. So I just want to make sure I'm encouraging people to speak up. Use the chat if you're not certain, but we really do want to hear from all the committee members as much as possible. So we'll begin with our roll call. And then after that, we are going to be going right into our meeting summary from the last meeting. We will need to take a formal approval of that. Then we will have public comments, and there are several people who are in line to speak today, so we'll be hearing from them. And then after that, we will be getting into some of the meat of the agenda. HMA will review the transitional solutions being considered by the commission, and we'll share some of the transitional solutions that were identified by all of you in the survey that we completed last month. Then we're going to hear from our commission chair, Vicki Lowe, who will present on lessons for universal healthcare from the Indian health delivery system. And finally, we'll come back to HMA, who will facilitate our discussion on options to include Medicare enrollees in a universal system. You'll note at the end of the materials, the FTAC charter, which was approved by the commission. It's in tab 7. So if you haven't already, please read through that charter. It provides guidelines for our work. If you have any questions about the charter, please feel free to raise them. And I'm going to turn it back to Angela, who will go through roll call and take us on to the next steps. Thanks, Angela.
Thanks, Pam. I'm going to call on members by first name in the order listed on the agenda. When your name is called, please unmute your microphone and then mute your microphone again. And we will start with Pam McEwen, please.
I'm here.
Thank you. Christine Eibner.
I'm here.
Thanks, Christine. David DiGiuseppe.
I'm here.
Nice to see you, David. Eddie Rouser.
Present.
Thanks, Eddie. Esther Lucero. Esther? Okay, and then Ian Doyle. And Ian let us know that he's going to be testifying on a couple of bills at the Hill today, so just wanted to double check on that. Kai Young.
I'm here.
Thanks, Kai. Robert Murray.
Present.
Thank you. And Roger Gantz.
I'm here, and I want to apologize for looking to the side. I can't get I'm a novice with Zoom, so I'm not getting oriented so I can see straight ahead. So side views will be.
That's just fine. Thanks, Roger. Okay, back to you, Pam.
Thanks, Angela. Okay, to Roger, I think a lot of us are looking to the side. That's just how Zoom works and how our cameras work. So the meeting summary is in tab 2, and the recording is posted on our webpage. And so I just want to ask if people have had an opportunity to read through the meeting summary. Does anyone have any questions or concerns, any corrections you think need to be made to the record? I'm not seeing anything. Are you, Angela?
No, I don't, nothing on my end.
Okay, I want to be thorough.
Yep.
Okay, then I would, seeing no concerns or questions, I'd like to propose that the minutes be accepted without change. Any discussion? All those in favor, please say aye.
Aye.
I think we got it. Any opposed? All right, the meeting summary is approved. Next, we'll move on to public comment. So committee members can find the written public comments under tab 3. And we allow individuals to sign up to provide public comment before the meeting. And we'll start with those who've signed up to provide comments. If you haven't signed up and would like to provide public comment, please raise your hand. Angela will keep a sharp eye out and she'll call on you after we hear from the individuals who've signed up. When you are called upon, please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps us ensure that everyone gets a chance to speak. And you are welcome to provide comments in writing via email anytime. To ensure that everyone has a chance, there's a limit of 90 seconds per person. We will be displaying a timer that you can see on the screen for the remainder. And when the timer stops, please stop your public comment. Angela, would you please start with the names of the individuals who have signed up to provide comment?
Yep. All right. First, we have Mike Benefiel, please. Mike Benefiel.
Thank you. I'm Mike Benefiel. I'm a Democrat PCO from LD 23. The problems with Washington's healthcare system are glaringly obvious. Insurance corporations are allowed total control of the system where their profits are more important than the lives of our family. For example, to enhance their profits, insurers are allowed to override doctors' treatment choices, potentially leading to unnecessary suffering and deaths. This should be criminal. The solution to the problems are also obvious. Eliminate the gross inefficiencies and exorbitant profits of the insurance corporations. While all other modern nations recognize this, our legislature still doesn't appear sure, even after the recommendation of their own work group's report. The report recommended that the problems be solved via the implementation of a single payer system. Such a system has been introduced for the last 3 sessions by Senator Hasegawa, the Washington Health Trust. But the legislature has chosen to ignore this bill in favor of a commission that has no published mission and no timeline for goals leading to legislation. There is no honest excuse to continue to ignore the Washington Health Trust legislation, SB 5335. Thank you.
Thank you, Mike. And next we'll hear from Catherine Lewandowski, followed by Ronnie Schur. So Catherine.
Thank you, committee members. Catherine Lewandowski, registered nurse, vice chair of Whole Washington. Today, I'd like to take a moment to share a letter from someone I work with at my small local hospital. My husband worked for our local school district and I worked at the local hospital. My husband and I both had good insurance and we owned a home. Unfortunately, my husband had a stroke in 2006. This event was the beginning of the collapse of our lives as we knew it. Life was much different in many aspects and not just medically. We were left going through numerous processes to figure out how we were going to get through with only one income. In attempts to keep health insurance, we were offered COBRA, which was $700 a month. On top of that new cost, his insulin was now $300 to $400 for 3 small vials. We did have long-term health insurance, however, that would take months to kick in. During this time, I was begging his doctors for samples of insulin just to get by. In my desperation, we were blessed to have our local Safeway pay for a 1-month supply of insulin. In 2008, I reached out by letter to President Obama since we fell into a donut hole with Medicare. I was looking for anyone who would listen. I was given hope to keep going when I received a beautiful letter back from him. In the end, we did have to finally file bankruptcy and let our home go. It has been 17 years. He has had many more strokes and open heart surgery. Back then, I was told that there were resources out there, but I never found them as I always made too much money. Now in 2023, I am working for the same local hospital, still as a CNA. I take care of my husband with the help of my children. This journey of ours, I wish upon no one. The need for healthcare for all, to help all families like mine who struggled for so long is important. People should not be losing their livelihoods and their homes that they've invested years of their lives in because a loved one gets sick. My friends, her story is not unique. We can and must do better for our people. Thank you.
Thank you, Catherine. Next, we'll hear from Ronnie Schur, followed by Roger Collier. Ronnie Schur, please.
I'm a retired pharmacist and president of Healthcare for All Washington and a co-chair of a coalition of other healthcare advocacy groups called Healthcare is a Human Right. And I wanted to comment on including Medicare in our state plan, the Universal Healthcare Commission's mission and goal. Medicare is a great option to study, a single payer plan that covers all elderly and additional disabled people. But I don't know of a way that can be included easily in our state plan. So I would urge the advisory committee to look at Medicare from the perspective of a model. And certainly Medicare presents some issues. We believe that an expanded and an improved and expanded Medicare for All program is a goal that we work on nationally. It's great to use that as an example for a plan that will work within Washington State, including as many different plans as possible or different options as possible under a single publicly funded program. So thank you for your work, for looking at Medicare, and please know that our group are willing to support any of you who have questions. So thank you for this opportunity.
Thank you, Ronnie. Next, we'll hear from Roger Collier, followed by Jen Nye. Roger Collier, please. Roger, are you able to come to the mic? Oh, I think you're muted.
There we go.
Great. Oh, Roger, you're muted again. Okay, I think we might have lost Roger. So Jen Nye, if you can come on, we can go ahead and proceed and maybe wait for Roger to come on. Thank you, Jen.
I'm here. Good afternoon. Oh, Roger, do you want to go ahead?
Okay. There's two places on the screen where you can mute, unfortunately, and I think I managed to get both of them. Okay, good afternoon. Because you're talking about Medicare this afternoon, I'd like to offer one or two comments on suggestions for including Medicare beneficiaries that were made at the last commission meeting. Okay, so simplifying a little, 3 suggestions. First, just moving all Medicare beneficiaries into the universal system with its presumably more generous benefits. Secondly, adding some kind of a wraparound like Medicare supplement. And third, allowing the universal system to function like a Medicare Advantage plan. Committee members are probably ahead of me already, but I'll go ahead. So problem, first, current Medicare law doesn't allow moving beneficiaries, so at least a waiver would be required. What might be a bigger problem, though, is expecting a political appointee in Washington, D.C. to agree to moving 1 million seniors, most of whom vote, from a program they're pretty satisfied with to something totally untested. Second, adding a wraparound like a Medigap option might be possible for beneficiaries in traditional Medicare, fee-for-service Medicare, but the regulations, Medicare regulations, very specifically don't allow it for Medicare Advantage. And that's what half the seniors in Washington have chosen. Third, allowing the universal system to function like a Medicare Advantage plan might encounter fewest regulatory obstacles, but only if participation were voluntary like other MA plans. And even then there will be opposition from insurers. So we already have a dozen or so Medicare Advantage plans, and those insurers are not going to be happy. Thank you.
Thank you, Roger. And Jen Nye, please.
Good afternoon. My name is Jen Nye, and I'm a PCO for the Democratic Party in the 34th LD. And I want to pitch the prospect of a public option as a means of transitioning to universal health care. The way we get to universal health care is to get more and more people on publicly funded programs. We don't get any closer when we encourage or assist people in purchasing private health insurance. In fact, we end up making insurance companies richer, powerful, and more entrenched. We must end the practice of giving away our taxpayer dollars in the form of subsidies to profiteers, because at its heart, private health insurance is an abusive relationship. You may get a low premium, but the problems start when you actually need care. You never know what will be denied, what you'll be charged, or if the plan is even accepted by your chosen provider. But a legitimate public option would be entirely different. We'd have a real choice, plan model A, if you will. People could select it on the exchange, or companies could choose it for their employees. We'd be able to vote for universal health care by picking the plan. And once we reached a majority or a predetermined milestone, the system could fully transition. I hope that FTAC can pursue the requirements that are needed to make this happen, because we simply have to start. Thank you.
Thank you, Jen. And that concludes anyone who signed up ahead of time. And we'd like to open it up now for anyone who hadn't had a chance to sign up, but who'd like to provide public comment. If you would like to provide public comment at this time, please raise your hand in Zoom. And Pam, I don't know if you're seeing anyone, but I don't see any hands raised. Give it just another second. Okay. Okay. This concludes our public comment period. Thank you.
Okay, thank you. Thanks to everyone who took the time to comment. We appreciate all the input that we are getting. I'm going to move us forward on under tab 4 of the meeting for the committee members, and here to facilitate the discussion on transitional solutions are Liz, John, and Gary from HMA. Thank you. Let's get started.
Hi there. Thanks, Pam. Great to hear from everyone today during the comment period. My name is Liz Argent. I'm from Health Management Associates, and we have, I'm happy to be here. We have two main objectives. Angela, if we could go to the next slide. Two main objectives of our conversations today, and they're going to be split apart. In the middle, we're going to be hearing from Vicki Lowe, chair of the commission. But just in general, what you're going to hear from the HMA team about are first, getting some input from all of you about transitional solutions to share with the Universal Healthcare Commission at between now and the next meeting. As you may recall, the commission is charged with putting forward transitional solutions, and they asked at the last meeting in February and asked for input from the FTAC. And so we're going to have a conversation today with all of you in response to some of the surveys that you completed and the information that we gathered from the commission to start beginning sorting out those options and what they might look like. And then our second conversation is focused on Medicare, and we heard a lot from the public just now about that. Sounds like most folks have gone through the materials. And again, I just want to emphasize that really we're beginning the conversation about Medicare, trying to understand what options may be available to make sure that there's universal coverage for consumers in our state, regardless of whether or not they're Medicare. Before I hand it over to John, who's going to facilitate our conversation about transitional solutions, I just want to ground everybody in our work plan and remind you of where we've been, where we are, and where we're going. So if we could go to the next slide, Angela. Thanks. Okay, so at our first meeting in January, we did a lot of process, getting trained and getting an overview of the work. Today, we are focused on, as I said, our transitional solutions, and then beginning to explore Medicare. The whole first year, if you look at this work plan, is really focused on trying to understand eligibility from the perspective of who we're going to be designing our program around. And the first two topics are Medicare, we'll be spending a few months on that, and then ERISA. But again, I just want to say today's conversation is really just to begin to provide some guidance and establish some more direction for the commission so that they can give, in turn, in April, give more direction to all of you about what they would like for you to begin further exploring. And then we'll come back again in May to have that more granular conversation. So today we're going to just stay focused at a high level. And I know Gary, who's going to be facilitating that conversation, is going to try to help keep it there, but also make sure that we're hearing from you enough so that the UHC can give you direction next time. So with that, I'm going to hand it over to John, and you can just, this is in your packet to see the work plan, but we're going to do this every meeting because there's a couple of months between our meetings. We want to make sure everybody is reminded of the path that the UHC has mapped out for the next year. So I'm going to hand it over to John now, who's going to talk about transitional solutions, and then we'll be hearing from all of you.
Thanks so much, Liz, and good afternoon, everyone. So I will start by saying thank you very much for taking the time to fill out the surveys. The survey responses yielded about 30 different distinct solutions to work through. So given the very robust agenda here, we'll try to make it through as many of those solutions as possible. But given that, I'm just going to go very quickly through the couple background slides here. If you can move to the next slide. So just as a reminder, the commission is tasked with considering transitional solutions for the state of Washington. It recommended a few kind of high-level recommendations in 2022. If you can move to the next slide. In January, we started a process of adding to that list and fleshing out some of those options with the commissioners. And then if you can move to the next slide. And then, sorry. And then in January, the commissioners also requested that the FTAC committee also weigh in on providing solutions that the state should consider as transitional solutions. So with that very brief background, I'd like to frame up the discussion here. So like I said, we've got a number of really great, very thoughtful solutions to consider here. In thinking about kind of a framework for discussion, I think what is going to be most helpful for the commission is to get a sense for each of these potential solutions qualitatively and kind of conceptually. What's the potential impact of the solution on healthcare costs, on equity, or access, or on quality, right? So we want to get a sense for, does this have potential for high impact on those goals and objectives, right? And then on a second dimension, are there significant barriers that potentially increase the resource intensiveness required to enact that solution, right? And so that could look like a number of different things. It could be significant statutory changes. It could be federal statutory changes. It could be state budgetary impacts. So we want to get a sense for from the FTAC, what's the sense of how challenging is it going to be to enact these solutions and implement them? If you can go to the next slide. So we kind of have framed up here just kind of a basic quadrant, right? And I'm going to talk through some of the proposed solutions. I'll kind of name it and then briefly kind of describe in a couple sentences the concept. and then open it up really to discussion. I'm not going to say who proposed each of these solutions, because most of the initial ones were proposed by multiple committee members. So definitely feel free to jump in and add a little bit more context if that's going to be helpful for the conversation. So
John,
let me.
I have a quick question. Just are these,
Yes,
do you have
please.
something in writing for us to look at, or are we just going to follow your verbal descriptions?
You're gonna have to follow my verbal description
Okay.
because we wanted to give as much time as possible for the
Fine.
survey results.
Okay, and I know you just recently got
Yeah.
everything dumped on you not that long ago. Okay, thanks.
But I think we'll be able to follow them because we'll do them one at a time, right?
Okay.
So first up is regulated hospital global budgets, right? So we had several folks propose this. Essentially, it's a model in which the state would pass legislative authority to one of the agencies or a governing body to establish global budgets for hospitals, and then control the growth of those budgets over time for all payer expenditures. So inherent in that would be controlling payments made in the commercial market, as well as, ostensibly in Medicare and Medicaid as well. So let me pause there. Would love for folks to weigh in and add context, but then please jump in and give us a sense for the potential for impact here, in this case, likely on cost, and then we can move to barriers.
John, this is Roger. Can we just talk in, or how would you like to handle our comments?
I think just jumping in would be great. And if we get a lot of comments coming in at the same time, we can raise hands.
Okay. Well, I guess there's a question. What I'm understanding, this proposal is essentially the model that Maryland's attempting to do with their inpatient hospital reimbursement system. I assume that's the case.
I think there can be variations on that theme, but yes, I think Maryland would be the essential model here.
Yeah. Well, I have one question just for thought on this, and it's a question. And I have to think a little bit more back with Maryland, but the issue, and I think it would probably work, is that if we were using sort of a budget-based model for hospitals, I struggle at times to understand to a degree how it gets integrated into a managed care delivery system, which is our primary delivery system, at least to date, with Medicaid and for public employees, how you incorporate those two. So I'm posing, I guess, as a question to think about, because as we mostly know that it's been at least state policy in general is that plans are left to their own accord to set their own rates. There's some exceptions to that, by the way, in Medicaid. But I guess that would be maybe a question I would have for thought on that subject. The other might be, and I'll stay with now, I promise I'll be quiet, is for a review. I know there's been some evaluation work, on the Maryland model. To me, it's a little a good concept. I'm not sure it's yet proved itself, and I guess I would be interested to see what we could dig up in terms of the evaluations to date of the Maryland model.
Yeah.
If I'm adding to something.
Yeah, I'd invite Bob to jump in if.
Yeah, I do have a fair amount of experience with this concept of hospital global budgets and also the Maryland system. I was the executive director at the regulatory agency in Maryland for a number of years. Just first off, with regard to your question about how would global budgets integrate with a managed care delivery system, I don't think there's any conflict per se. Global budget system would be highly complementary of managed care approaches to help control use of services it would supplant the managed care entity's ability to set their own price, but that's not a bad thing. I think part of the problem is right now the payment system in private health insurance, whether it's managed care or indemnity insurance or whatever, it's too fragmented. And there are other factors that also don't put pressure on insurers to be good stewards of cost control. So the global budget would usurp that ability of these individual plans to negotiate rates, but that's not a bad thing. I think this would create a much larger purchasing power to help achieve the primary goal, which would be cost containment. But in Maryland, there are managed care structures, Kaiser, MA plans, Medicaid managed care, and so on. They work just fine under the global budget in Maryland. With regard to Maryland's system, I don't think you have to duplicate Maryland system, nor would I advocate doing that. Maryland system's very complicated. It's been sort of layered on an old, very complicated unit rate system, but you don't need that type of complication to do global budgets. There have been other demonstrations, one in particular in Rochester, New York, where they set global budgets for 9 Rochester area hospitals. But they regulate at the global budget level. They don't regulate at the unit, the service price level, which tends to make the system very complicated. So in other words, you can make a global budget system and the authority much less complicated and just focus on regulating overall hospital global budgets and the growth of those budgets over time, and thereby making it a less complicated system and requiring less regulatory expertise and oversight. So there's sort of the Maryland system's out there. I'm not suggesting duplicating Maryland because it has too many bells and whistles that you don't need, but global budget systems have worked quite effectively elsewhere, both in the United States and internationally. So hopefully that answered those questions. So I'm happy to answer other questions. In terms of positioning it, my recommendation is that I think it could have a high impact. It would be slightly more on the more intensive quadrant, but not significantly so, because if you did it like Maryland, it would be highly complex and intensive, but I would even move it down a little bit lower, right? But I think it has a very high impact, so I would move it more to the right. That's my recommendation, at least.
I agree. Eddie has hand up.
Yeah, I was just following this discussion, and I was trying to understand how it would fit into the capitated amount. And so it's more like it's an administrative services only to the MCO that then passes through the cost that's set at the hospital by the state. Is that my interpretation? So,
well, it would govern the amount that hospitals could actually charge their patients, and that would be for all patients, managed care as well as others. And so it sets a constraint for each hospital on an aggregate basis about what their overall net revenues would be. And it would be prorated in essence down to each individual payer category, whether it's commercial, Medicare, or Medicaid. So I'm not sure I follow your question. I mean, for managed care in most cases, they don't pay hospitals a capitated amount per se. They'll pay whatever the service amount is, per service provided under a fee-for-service structure, and that's predominantly the payment structure for hospital services and hospital care. But I would imagine both in most every state and also Washington. So the global budgets would try to work to constrain the price level that each managed care or insurer would face for their covered services, and also control the rate of growth of those payments over time.
but would the state pay the MCO, the PMPM at an administrative amount,
right,
and then the hospital would have its rate set by the state?
Yes.
Okay.
Now, in terms of complexity and intensity, one of the major challenges for this type of model is a political challenge. Getting legislature to pass legislation sufficient to give a regulatory agency the authority to regulate this. For some reason, I still haven't figured out the Americans are against regulatory or governmental involvement in that type of thing in the United States, when virtually every other developed country in the world has a regulated payment system like this, either global budgets or setting fees. So that's a reality in the United States. Maybe it's a little easier in a state like Washington, but it still creates a challenge to pass legislation to do this type of thing or any payment model.
Thank you.
And Bob, just to get a quick reminder, and CMS has indicated that they're going to propose a model for global budgets, and likely it'll have fewer moving parts than the Maryland model. But I hope. I mean, I've strongly advocated that to them to try to move away from the Maryland model in many respects, because I having sort of created this beast back in the 2000 period, I recognize acutely, probably better than anybody, the weaknesses of some of the things that Maryland does. So there's a better way of doing it, I think, yes.
And I think we've set aside time for future meetings to get to, bring Bob on and really dive into some of these things a little deeper so we can understand them better.
So great. I think with that, Pam, should I move to the next solution?
I think so. I'm going to count on people to raise their hands or jump in if they still have more to say.
Perfect. So the next proposed solution, also, several people kind of raised this, is out-of-network price caps. Out of network price caps, a percentage of the total care delivered in the commercial markets as well as in the managed care markets occur out of network. And the thought here is that there would be a cap on what those providers could be reimbursed, potentially pegged to Medicare rates. And with that cap in place, it removes some of the leverage that those providers have in order to negotiate or stay out of a network, right? So in theory and in practice, in some cases, it has an impact on actual negotiated network prices itself, right? So let me pause there. Any of the folks who have thoughts on this, please weigh in.
While people are gathering their thoughts, I want to, if we run over, there's so much content here, it's so rich that if we run over anybody, please feel free to use chat also to, make comments or ask questions.
If I could jump in here, this is actually a payment model I've thought about a lot. And I think you've positioned it fairly accurately. I think it's far less intensive than regulated global budgets or something that regulates all payments. Because it only applies to out-of-network services, which are probably in the 6 to 9% of total services proportion. So it's not regulating everything; it's only regulating out-of-network. But as you said before, it has the ability to have positive spillover effects on the negotiating leverage of insurers to negotiate lower in-network rates, which is the vast majority of services are in-network. And that the reason why that is an insurer could say, if you set a cap, an out-of-network cap at say 200% of Medicare, the insurer could say, look, either you accept my in-network rates at 200% of network, or I kick you out of the network and you are paid 200% of Medicare. It basically reverses the leverage that providers now have, where they threaten in the opposite direction. They'll say, look, I want a rate increase in my in-network rates, or I'm going out of network and I'm going to bill you full charges for all your remaining members. And that happens a lot in negotiations. It's not something that's publicized, but happens a lot. So this removes that leverage and then turns the tables and gives leverage to insurers to negotiate lower rates. Now, there are issues associated with whether the savings would be passed through or not, but for the self-funded accounts, it would be passed through directly. And then hopefully there would be some oversight from the state insurance commission that would ensure that any reductions in in-network care would be translated into lower premiums. But it's definitely something that works, and it works well in the context of Medicare Advantage, where they have this out-of-network price cap installed, and it has lowered in-network rates tremendously. So again, it's a lower intensity rate regulatory approach.
So Bob, would you mind weighing in with a sense of impact? And I think the intention was to move up global budgets to higher impact.
Yeah, I think global budgets has a higher impact. It probably has a little higher resource requirement too, just because of the political aspect of it. But for out of network, I would move it a little bit more to the right. Yeah, and probably around there. Yeah, that's probably fine. I think it has a little more impact, a little less impact than regulated global budgets in terms of costs. So I'd move global budgets a little more to the right and out of network a little more to the left in terms of cost. But in terms of political, difficulty or challenges, you might want to move global budgets up a bit, because I just don't know the political dynamics. I think the biggest challenge is getting some legislation through politically in any state.
Yeah. So,
Roger.
just a quick question on the out-of-network price caps. And you mentioned Medicare. So the question is, could this not be also in part accomplished through the contracting process of, let's say, of the healthcare authority when they're contracting with health plans? Could they not specify to agree those sort of provisions in a contract? Or we need enabling legislation?
I think you need legislation because this should apply more broadly to the commercial market. It wouldn't be just whatever the health care authority has oversight over. So this would be applicable to all commercial insurers.
Gotcha. Okay.
That helps to understand the resource requirement, which is you do need legislative authorization.
Right.
Some of these.
But there are entities in Washington.
I wanted to note that I misspoke, and when I encourage people to use the chat function, if anyone tried to do that, you might have discovered it's disabled. I'm sorry. So please do make an effort to raise hands, and we will take comments later. But I'm going to watch for hands, or please feel free to jump in.
Can I just make a quick comment? I'm wondering if we're putting things on the chart wrong, and apologies if I'm just reading this wrong, but I feel like low income impact is on the y-axis. So out of network, we have in a low impact quadrant. Is that what we had intended?
Yeah, we need to flip the axes. Sorry, I tried to enter that in the chat and realized it was disabled.
Yeah.
Thank you. Any other thoughts from committee members? Would love to get some opinions here as well on both of these before we move on. Love to get a sense for, does anybody kind of disagree with their placement, that this is going to be harder, less difficult to implement, or greater, lower impact?
We have people here with health plan experience, with all kinds of other experience. If they want to weigh in or add any comments.
Hi, this is Eddie again. Just a quick question. So when you say that price cap, what is that a multiple of that you know when you're saying it? Is it like 2-3 times Medicare pricing?
I think it will vary from region to region or state to state, but yeah, I think the state would need to take do a survey. I think in the context of Cascade Care, there was some analysis that said that current commercial payments are about 170% of Medicare. So you want to take a look at the current structure of payment and level of payment, and also how it varies regionally. But it would probably be in that 170 to 200% range. In Oregon, the State and Health Employee Benefit Program just implemented a price cap for that program. It was 200% of Medicare for in-network, and 185% for out-of-network services. So say it's going to be in that range, probably 170 to 200%, but it really kind of depends upon the current lay of the land.
And this provides some stability when setting premiums, because they'll have some type of cap.
Right, should. And the cap would translate into lower in-network rates and then produce savings for the insurer, which hopefully would be passed on to the premiums, the premium payers.
Bob, were you saying that Oregon has done that with their public employee purchasing?
Yeah, they've set caps both on in-network and out-of-network, so it's a little more expanded. It covers all services that they hospital services for their state and public employees. Yes.
Okay, thank you.
Christine has her hand raised.
Hi, yeah, I just wanted to point out for the out-of-network price caps, I think the CBO has viewed this a little more favorably. We have it fairly low on the quadrant, and I don't know, I realize this is all subjective. It might be worth looking at, the other thing is I feel a little uncomfortable making these kind of judgments off the cuff, right? Because there's a lot of research on these things and we could probably go back and do a more comprehensive review, but I think CBO has put that up a little bit higher.
Yeah, I think I would agree with you, Christine, about that. But I also want to just say the off the cuff, in some ways, we're just kind of taking the temperature of the room right now, and we'll come back and give this a little bit more of a vein and more of an in-depth discussion. So it's okay if it's a little bit of a rough draft right now. David.
I think there's a sense that we need to narrow the field a little bit before we can dive very deeply.
Yeah.
Yeah, Pam, just since you asked for a health plan perspective, just having worked in one health plan, I have no problem with the placement or the rationale for why these are here, and I don't have any added rationale for these particular items.
Great. Okay, so moving to the next proposed solution was that in several people, in recognition that there are a lot of different models right now out there for regulating provider reimbursement, that it would be prudent to start with a study of provider rate regulatory approaches. And we could look at the potential impact of both of the options that we've discussed, as well as other ones related to cost growth targets and so forth. So any thoughts on that approach, or that starting point rather?
Yeah, a quick thought on some of these areas when we're talking about rates and the like. An encouragement note would be is to have some further coordination with our healthcare cost transparency board, since to a degree they're wrestling with some of the same issues. It might be an area that one, another one that we could coordinate our work with theirs.
Okay, good point.
John, is this basically saying the two ideas proposed earlier would need to be studied in terms of regulatory methods to achieve those?
David, I think it's recognizing that there are a number of different approaches, including those two out there. But the state wouldn't want to try multiple of these, right? You'd want to select kind of one that's going to have the highest impact or be the best fit for the state, right? So it's just saying as a starting point before kind of going down the path, at the very least, in the short term, should we study this?
Yeah, it strikes me that concept could apply to every idea that
any of them
we're going to pull on to.
So given that statement, David, should we read low impact, or I don't want to put words in your mouth?
Well, I guess my thought would be that this is a great point, that any idea that's being proposed here, there should be some analysis of the pros and cons and the impact of. So I don't know that I would consider it a solution so much as an approach to next steps.
Absolutely. That makes sense. Does anybody disagree with David's approach there, because I think we could absolutely handle it in that way.
I would just disagree with myself if the person who suggested it is saying that we may not have the full universe of ideas on the sheet that you're pulling from, which is certainly a valid perspective.
Yeah. We have about 10 minutes left on this discussion, so we might want to, throw some more things up on the board. And
Let me get, yeah, absolutely. Okay, so let me get a couple more things up on the board. So consolidated state purchasing was another one that occurred several times. So the thought here is that the state purchases healthcare in a couple different markets, and then Medicaid, PEB and SEB, and then depending on how you characterize it, actively purchases Cascade Select plans as well through a procurement process. So aligning those procurement processes either in part by kind of including some common elements, like for example quality requirements, etc., or more kind of concretely by pulling all of those procurement processes under a single process, or at least a kind of single governing entity, right? So essentially pulling them all under one agency and one division. I think this was a pretty kind of broad-ranging solution, actually. So we may have a little bit more conversation here on defining this and then trying to put this on the impact scale here.
John, this is Roger. I would like to encourage that, because there are a variety. I'll give a couple examples, things to say about aligning things. For an example, there is not a complete alignment in terms of quality improvement measures just within the state itself. Medicaid has its group, UMP's got it a bit. I don't know about SEB at the moment. I can't speak, Pam, I should, for the exchange, and they're not in line. So one thing you say, well, that ought to be a kind of a low-hanging fruit one, to bring those all into line so we have consistent incentives. That said, when I see consolidated state purchasing, and this is why we should have a further conversation, I'm thinking of something much more significant than just aligning small partial components of the purchasing effort. So
can you say a little bit more about that, Roger? Like what would be that kind of high impact consolidation approach?
I'll give an example. I don't have the numbers quite in front of me, but through the state itself, we control about over 30% of the insured market, and I'm including that within including Medicare, Medicaid, and PEP, SEB, and the exchange. And I think what this model would, at least as I see it, would say is we're going to bring those all together. And by all together, to me, I know this is not such a simple task, but all together as in this world of moving towards a single payer system and the like, having at least a standardized benefit that crosses all of those folks, those eligibility groups. It involves the state going out and contracting with plans, probably on a selective contracting basis, to say, do you want a portion of this business or not? And that structure can be arranged in a variety of ways. There's a lot of detail I want to take our time with today, but that's the basic notion. I'll say it one more time. It's a consolidated purchasing, and I don't mean this as a blasphemy, but today we have, within the healthcare authority, my old program, the Medicaid program, we have SEB and PEB, for example. They are not purchased together. They're not. So the leverage that in theory could be for that is not achieved there. And I understand all the politics and all that, why that's not the case, but this sort of a model suggests that yes, that would be the case, that we would do this type of a consolidated purchasing, where you use the leverage of, 30% of the insured market, to at least for that end of it, to drive price and quality.
Yeah. So Roger, would you give this high impact?
Yes, I would give it a high impact. I would give it a higher impact than, quite frankly. Yes. I would give it a very high impact. I understand that it's, when I say it's more resource intense, it is that without question. And I fully appreciate, Pam, as I know you do, that this is not an easy lift. But I'll say one last thing about this. But if the Uniform Healthcare Commission is going to be, eventually moving towards some notion of a unified health system, that has huge implications. We'll be talking about that time and again. And if we can't do that with the world that we control as a state, then I don't know how we're going to move effectively towards a more broader vision of bringing in Medicare and ERISA, et cetera. So I'm mixing two things here. I think it's critical, and yes, it is high impact, and I appreciate that it's high resource.
Just a quick question. I'm not sure why it's high impact as regulated hospital global budgets. Global budgets will regulate all sectors, commercial, Medicare, Medicaid. Consolidated purchasing, as I understand it, would be primarily just the state employee program integrating itself. And that's a fairly small segment of the market. And then maybe to the extent that you could have some coordination with Medicare or Medicaid and the state exchange or the public option. But that's a much smaller proportion of the total market than global budgets, is my point. So I'm not sure why it is a higher impact.
Well, I guess this is for a great further discussion. I personally don't agree. And when I think about this, I want to be clear about this. It's not just state employees or public employees. It brings in Medicare. It's about 30% of the total insured market. That's a large chunk of it. And as a first step, or at least a step is to moving towards consolidated purchasing. Quite frankly, you could put global budgeting underneath state purchasing as a way of starting that.
I don't see how it brings in Medicare. I think that's wrong. But Medicaid, maybe there could be allegiance or connections, but it just depends. It depends on how the state implements it. Sorry, I don't want to take up time because I know we're running short.
Okay, I think we can come back to that too. I think there's a lot to say about that one. Kai, your hands up.
Yeah, I think my comment is that, this notion of consolidating state purchasing, I think could be a potential framework for hanging some of the other ideas that we have on the sort of prior slide one. Like for instance, standardizing benefit design. One of the first initial steps you might pursue in that area is just standardizing measurement of cost and quality, right? Like, and that can be done right across these state entities in the same way, right? And standardizing claims adjudication, right? And in of themselves, right? These are smaller solutions that are like 1%, estimated from scientific studies, 1 or 2 or 3%, of either commercial or Medicare size budgets, but they add up and can add to that consolidated state purchasing overall cost impact.
That's a great point. It's kind of a vehicle for getting some of these other at least partially enacted, right? Okay. Pam, do we have time for like one more maybe?
I think we do. I'm not sure that the staff agrees with me, but I'd like to try one more.
Can we at least hit auto enrollment for Medicaid? For folks who are deemed ineligible for Medicaid, auto enrolled into exchange plans, so as a way to ensure continuity of coverage.
That's in my wheelhouse, and I know we're trying to move, so I'm going to just go ahead and jump in. It's doable. It's being done in other states. This would be for people whose eligibility changes from Medicaid to a qualified health plan, right now they drop out, and then they are really hard to hang on to because the sticker shock happens at a very, even at very affordable rates. Other states are doing this. There's some tricky things about it, but it is being done. I think it's high impact if you look at the uninsured. I think it helps you kind of really take on that small number of uninsured in the state. And I think it's resource intensive for the exchange and the healthcare authority, but in terms of the kind of some of the other ideas that came up, like, regulated hospital global budgets, you get a lot of resistance on a topic like that. But auto enrollment to Medicaid, I don't think the resistance is there. I think it's less resource intensive.
I'd add to Kevin, I alluded to. I would add to that. I mean, I think, as you know, just today is that the exchange is really the conduit for almost all Medicaid beneficiaries, with the exception of, categorically need AIDS, blind, disabled. They go down another path at some point in time. But the large majority of folks come in through the exchange. They get moved over to ACEs, where they sit there to move that information back over between the. I don't want to trivialize it, but it is doable. It is doable.
It's
I
doable.
would support that.
Yeah, we probably Eddie, I see hand.
Yeah, just this one was a great one, I think, to put up there today, because what we're going through this year is the unenrollment, essentially the downside of ending the PHE. So if this was ever a timely thing to talk about, it would be this, and hopefully there's some vehicle in place already to deal with this.
Yeah.
But yeah, and the way that currently would be presented to those individuals that are going to be getting notes in the next 6 months is, yeah, it's a big one.
Okay.
Well, thank you very much. Great discussion. More to come, certainly. I will hand it back over to you, Pam.
On this question one more time, I'm sorry. Could that list that you put together originally, could we get a copy of it?
Is that ready, John? Is that shareable yet?
Just even the list, the basic list.
This one?
The basic list.
That's because I think
it would
help us kind of think about it, and maybe be a little more constructive in our own minds about our own ideas about where to bucket things. So if that,
yeah, absolutely.
We might
send it out.
We might come up with a homework assignment.
Yep.
Another survey.
Yeah. I want to move ahead. Thank you, John. And I agree. It was a really great discussion. And we didn't take too much time away from our chair, Vicki Lowe, who is ready to launch into lessons for universal healthcare from the Indian health delivery system. So Vicki, are you ready to go?
Thank you, Pam. Yes, I am. I Squatchy. Good afternoon. Vicki Lowe since Sna Statithlam News Sklayam. I am Jamestown Sklallam since Sna Bella Kula First Nations or New Hawk. And I'm actually here today in my role as the executive director for the American Indian Health Commission of Washington State. I've worked in the Indian healthcare delivery system for over 26 years. It's hard to say that sometimes. And I just wanted to share some of these really high level concepts about the Indian healthcare delivery system, because it really is a universal system, but it does have its issues, but sometimes it's hard. You guys are doing a better job than we are at the commissioners' meetings, really thinking outside of healthcare coverage. But just wanted to share some things with you and answer any questions, kind of get some ideas going. So if you can go to the next slide. So I want to talk about the differentiating between a system of care and coverage, and then give a little bit of understanding of how direct care and purchase referred care works within the Indian healthcare delivery system, and then share with you a little bit about the program I ran at the Jamestown Sklallam tribe for almost 20 years. Next slide. So as I said, Indian Health Service is a system of care, much like the Veterans Administration. So there are 3 types of facilities. There's the Indian Health Services facilities, tribal facilities, and urban Indian health programs. And they're both funded in all 3 funded in very different ways. Indian Health Service facilities are operated by the Indian Health Services Program. So they're federally operated. The tribal facilities are operated by tribes, and the urban Indian health programs are operated as federally qualified health centers under HRSA, and they have a whole bunch of ways that they get funding for their services. But most importantly, the providers and the facilities, especially in the IHS and tribal clinics, are funded on an annual basis, and they are funded through an agreement based on the services provided. So your agreement says which services you're going to provide, and then you have to show your user population. For tribal compact and contract tribes, they compact their funds and their different line items out of the budget down from the Indian Health Services. Then there is a 3-year look back period on their user population to establish who is a patient of the clinic, and that's how the funding is given to them. Next slide. And then again, you guys probably know a lot more about this, but systems of care are really about coverage is based on your geography and your location near a facility. The facility and provider payments are based again on that annual per person per year calculation. There's less administrative burden for providing care because you're not trained to work with different insurance carriers and, Medicare, Medicaid, all the other federal programs, and figuring out the different authorizations processes. You can have one authorization process for all of the different patients. And then IHS funding happens after the service is received, which I don't know if the Veterans Administration works that way. And I think that's a little bit of a weakness of the system. So you have to provide the services up front and then get paid by drawing down the funds. And then there is a prior authorization system for referred services, and it's based on need and availability of funds. And again, I think this is one of the issues with Indian Health Services. The funding is an appropriation and not an entitlement program, so that when the funds run out during the year, you don't get more funds. You have to make the funds last all year or people go without services. And then looking again at the coverage side, it's more portable based on finding a contract provider. There are 2 types of providers. There are more, but basically 2 types of providers: fee for service, where they get paid when they provide a service, or like the Medicaid managed care model, where you get a per member per month payment. Again, the fee for service payment happens after the service is provided, and the PMPM happens at the beginning of the month. And prior authorization for referred services are different based on whatever coverage a patient has, which again, I think is a weakness. Next slide. And then in the Indian Healthcare Delivery System, for the purchase and referred care program, that is when we pay for services received outside of the Indian Healthcare Delivery System. In other areas throughout the United States, they're in the Indian Health Services areas, they have IHS operated hospitals. So many of the tribal members can be referred from the Indian Health or tribal clinic to the IHS hospital, or if there's specialty care there as well, without it being a cost to the program. But in the Portland area where Washington State is, we do not have an IHS funded hospital. So all of that care has to be purchased outside of the Indian Healthcare Delivery System. And so there is a system of care, and the payment for that system is based on the Medicare payment methodology. So if a provider accepts a patient from the Indian Healthcare Delivery System to either a hospital or a specialty care service, they are accepting that Medicare-like rate. And that has only been in place for the specialty care since 2017, and has been in place for hospital care since 2005, and has really helped save a lot of those funds by having that Medicare payment methodology as part of the formula for their care referred outside of the clinics. Next slide. Oh, I think I already said all that stuff, sorry. I'll go back. One last thing is IHS does have like a stop loss coverage. It's called the Catastrophic Health Emergency Fund. So if you spend more than $25,000 for a person on an episode of care, then the Indian Health Services program can pay back for those services. Okay, now next slide. And this is a little bit old, but I haven't found an updated one yet. This is from 2020, it looks like, but it's 2018 expenditures. And it's a report on the federal, so national expenditure per person based on their coverage. So again, starting at the left, if we look, that's the Medicare per person per year. It was $13,257. And if you look in the middle, the VA was $9,500, Medicaid $8,000, and on the end there is Indian Health Services, which is by more than half less than what Medicaid receives. So I think if we look at the Indian Health Services and people are worried about the disparities, there are a lot of reasons for them. And one of them is the chronic underfunding. So just it's important that when we build a system, we make sure that we continue to pay for it appropriately. And then next slide. And then I just want to tell you a little bit about the program I ran at Jamestown. We didn't have a clinic. We're a pretty small tribe up here on the peninsula, Olympic Peninsula. And the Indian Health Services clinic that we were eligible, or people were eligible to go to, was still is in Nia Bay. And if you know anything about the geography of the Olympic Peninsula, that is a long drive and roads that oftentimes are washed out during the winter. And then eventually there was a clinic in Port Angeles, so 20 miles from where our tribal government is at the lower Elwha Clown tribe. But the tribe decided they wanted to have better access, so they compacted their funds down in an agreement with the federal government and started purchasing insurance. But instead of just using the coverage and being okay with it, the tribe established a level of benefits they wanted for their tribal members. And then we took each of the coverage. So if somebody was eligible for Medicare, we would pay reimburse them for their Medicare Part B. We would purchase them a Medicare supplemental. And this was back in the 90s when we started. So a Medicare supplemental was like $32 a month, which is crazy to think about now. And then this was before Medicare Part D. So we would put them on a prescription drug plan, and now we buy the D coverage for them. If they were on Medicaid, we would, help them stay eligible, help them with their paperwork, and then purchase the wraparound services that they might not be eligible for in Medicaid or Medicare. We had to purchase dental and vision for the Medicare enrollees. And then if somebody had private insurance or employee insurance, we again would reimburse them for their premiums and any co-pays and cost sharing that they had. And then that was back in the good old days of basic health. So we had a basic health subsidized and non-subsidized group. So we would help people sign up for those coverages and keep them on those. And then as benefits change, we change, how, with the programs. And so that someone's income really didn't impact their coverage. They all had the same level of coverage. And even today, if you asked one of our tribal members what coverage they're on or what their insurance is, they will tell you they're on the tribe's program. Even if they're on Medicare or employee insurance, to them, it's the tribe's program because everything goes through there and then they get that same level of benefit. And I think, is that my last slide? Yep, and there's my contact information in my day job. But I just really wanted to share that information with you guys because I think it's helpful to kind of think outside of the box that we live in insurance coverage. Do you have any questions? Hey, Roger.
Hi, Vic. It's good to see you.
You too.
I promise I'll be short a couple questions, but
well, I don't believe you.
I don't believe you. But if you might share with folks again, because I think it's really quite extraordinary, and I believe it came out of the Indian Self-Determination Education Act of 1975, that maybe set forward a structure for tribes to administer their own programs. And I think this is accurate, Vic, and then I'll shut up on this, is that today, 28 of the 29 federally recognized tribes in Washington operate under those compact provisions. Is that?
Absolutely, yes. And more than half of the funds that flow through the Indian Health Services, the federal program, go to tribes in the United States to operate their own programs. So self-governance, which kind of started up here in this corner of the United States, and Jamestown was a big part of, has really spread out. And, you know, for our tribal members, they really wanted to keep their ability to see the providers they're already seeing. Now, we ended up building this fantastic clinic and they want to go there now, but it just gave them access and they didn't have to worry about, you know, dealing with calling an 800 number and getting a purchase order and all that. So it's been great. But yes, it does stem. We've got a whole bunch of training about the federal trust responsibility and how that all works. And I'm happy to share those links if anybody wants to see some videos.
One last question, I promise to be quiet. Vic, you know that you know, as we go through, and as you, of course, you being the chairperson of the Universal Healthcare Commission, we're going to be talking about programs like the integration of, excuse me, Medicaid and Medicare. And I'm just, you know, I'm quite familiar with Medicaid. And if I'm correct in this, Medicaid is probably the largest outside funding source, non-IHS or tribal related, that I know Washington's tribes are, and I expect that's the case nationally. So my point is, as we talk about Medicaid or Medicare, this has obviously some major implications for the tribes. And here's my question, I haven't said that, is as we go forward, and both the FTAC and the Universal Healthcare Commission, what is your guidance about working with the tribes, the tribal consultation process, and maybe more informally, as we're thinking about ideas and having discussions about what do we do with that tribal delivery system, a vehicle that we can have some conversations, I expect maybe through the American Indian Health Commission, to fare out and exchange ideas. Could you provide some guidance on that?
Oh, yeah, absolutely. So first of all, the reason I applied to the Universal Healthcare Commission to be a commissioner was because I was worried about the impacts on the Indian healthcare delivery system, because those funding sources, as you mentioned, are, you know, third-party revenues fund tribal clinics better than Indian Health Services does. Indian Health Services only funds us at 32 cents for every dollar we need to provide care. So yes, we have some language that we wrote, the American Indian Health Commission, that would be draft language for any universal health care bill. We've shared it at the federal level with Representative Jayapal. And because there's 29 federally recognized tribes, they're all very unique in how they run their programs. So just to really high level it's like we would like to be exempt with the opportunity to opt in if a tribe so chooses. And there's a lot, I mean, there is a lot behind all of that too. So that's really high level.
Can you share that with us or with the commission at some point?
Yes, I can, definitely.
Thank you.
All right, thank you. Kai?
Yeah, thanks for the presentation. So my question is, could you comment a little bit about, you know, how this particular system of care and coverage, you know, impacts, you know, quality of care within the IHS, setting aside, you know, the really important questions for the moment of like, you know, SDOH and the level of funding that you have, but just how this arrangement, you know, influences quality.
Yeah, it's so, you know, Native Americans been providing whole person care since time immemorial. So this isn't new to us, the idea of helping the whole person. And the tribes are also government, so they provide other governmental services. So a lot of those social determinants of health the services are already available within the tribal governmental services. So it's a little bit easier to do that work because we're, you know, a smaller scale of a government working together. And unfortunately, because of underfunding, staff at a tribe are probably the best at finding and knowing any resources that are available in the area, because we also know we have to utilize what's out there. So I think if we could have full funding, we see great innovations because our providers aren't as focused on the funding as I think some of the hospital systems or other systems. And so I think a system of care where you're not worrying about what coverage somebody's on and you know, what the authorization is for this and that really lets providers and the staff focus on providing quality of care. Does that answer your question?
Yeah, thank you.
Thank you. Okay, Pam, I'm 1 minute over. No, right? Any other questions?
Pam, you're muted.
Thank you, Angela. Are there any more questions? Okay.
All right, well, that's my email there. And I will share some of the resources that Roger asked about with you. And just thank you all for your time. And thank you for doing this work. I know we're all volunteers and you guys, I just really appreciated the conversation before this because you guys know so much. It's just gonna really be helpful. So thank you.
Thank you, Vicki. Thank you for chairing this whole process, which is a big job. Okay, we're going to move on to the Medicare discussion, and I want to welcome Gary Cohn from HMA, who's going to facilitate this.
Thanks very much, Pam. As we've already discussed some today, I think we all recognize that the issue of how to address Medicare beneficiaries in a uniform financing system run by the state is both important and complex. As a federal program, clearly the state doesn't have either the direct authority or even the regulatory authority that it does as it has under the state based programs. And so the commission is very interested in guidance from you all as to the best way to proceed. Next slide, please. So this slide just has some quotes from work that has been done in Oregon and California to ground us a little bit. I think everyone who has looked at this has recognized that there is currently no authority that would allow the federal government, CMS, to permit all the funding, the money that the federal government spends directly providing services in fee-for-service Medicare or to the Medicare Advantage plans, put that in a pot together with other sources and create a uniform financing system using that money to help pay for it. There is no single waiver authority. So something would have to be done that would be either through Congress or some kind of other mechanism that so far hasn't been used. So it would be novel and unprecedented, as the Oregon task force said, in order to be able to do that. Next slide, please. So at the last Universal Healthcare Commission, there was a consensus to address two different options for what to do about the Medicare beneficiaries in order to accomplish the goal that everyone in the state would have culturally appropriate healthcare and universal coverage. And in particular, that the benefits that would be provided for all Washingtonians would be comparable, much along the lines of what Vicki was just talking about that Jamestown has done. So the two pathways that were discussed and where the Commission is interested in help from you all is, one, whether a state-run Medicare Advantage plan is a viable option to cover Medicare enrollees' non-covered benefits, and secondly, whether there are other options to wrap around Medicare benefits so that all enrollees in the state receive the same benefits. Next slide, please, Angela. So turning to the option of exploring a Medicare Advantage plan, I think the Commission has identified, very broadly speaking, the what, and they're interested in some additional help from you all in terms of the how. And for today, the questions that we have are really around what work would need to be done in order to determine whether this is a viable solution, viable legally, certainly, but also viable in a practical way. What questions would need to be answered regarding how this would be administered? For example, administered by the state through state employees or administered through existing Medicare Advantage plans, much the way that Cascade Care Select is done today. And what analysis of costs and benefits would be needed in order to evaluate whether this option makes sense for the state. And so, those are sort of the broad questions that would be helpful for the commission to hear from you all, but obviously we want to hear any other thoughts that you have on this particular option.
Could I just ask a question? I'm having a hard time wrapping my head around what all would be involved in this option. So this would be, when you said state-run oversight of Medicare Advantage, what would the state authority do, and how is this link into the overall concept of universal health care?
Well,
go ahead.
So currently, as somebody I think mentioned, people who are on Medicare have a choice today. They can be in traditional fee-for-service Medicare, or they can enroll in a Medicare Advantage plan that's offered by a commercial insurance company. And so the idea here is, in order to try to provide a state-run option, the state would essentially administer a Medicare Advantage plan. And the goal would be to have the benefits be, if cost savings could be realized, and the benefits could include things that currently are not included under Medicare, chiefly vision, hearing, dental, and long-term care are the big ticket items that are not included under Medicare. That option would be available to people in the state, and over time potentially could become the dominant way that Washingtonians receive their Medicare coverage.
Can I follow up on that? Just with another further question. This is Roger. Okay.
Of course.
I'm sorry, I didn't mean to talk over. So, I tried to wrestle with this a little bit when I've looked at, particularly the proposal that came out of Oregon, and kind of to a degree, California did. They were embracing Medicare as part of a consolidated, single, unified purchasing system. I know this gets to be old news again, and I guess one of the things I would, maybe suggest or maybe recommend back to the commission is, given all the challenges around this, is this something, and this being, the state being a managed care plan or purchasing it, something we want to engage in at this time? By that I mean is, somebody came up for, well, you guys want to be a Medicaid Advantage plan? I mean, why in of itself would the state want to do that? It's kind of a rhetorical one, because I said, well, we can go out and maybe get a better deal for beneficiaries and we have, by the way, 17 managed care companies in Washington now. We could go out and get equal or a better deal than them. That's probably kind of part of the argument. I'm not sure how we would do that. And so
well, I think that's exactly you've put the question that really needs to be addressed, and where the commission is helping to get some guidance from all of your expertise and experience. The question is that something that is worth pursuing because of the potential benefits of it, given the challenges that exist in doing it?
Well, I have one recommendation then, and this is maybe a question we're not going to answer today, but it's back to our questions previously about analysis. It seems to, to kind of provide some further guidance to the commission, is to say it would be helpful and I'll give a specific examples. It looked at some trend analysis over time. For example, what the managed care plans in Washington, we can, those plans, what are average per capita growth rates in those? What's been the average per capita growth rates, for the state with respect to its contracting with Kaiser? And another one would be, what is its average per capita growth rates with respect to UMP, which is essentially, a self-insured plan. And the reason, I'm kind of asking some of that is it kind of begs the question. We're kind of assuming that the state somehow, as a purchasing entity, can get a, lack of better words, a better deal than what's existing out there in the market today. And I mean, if we're all under one consolidated, system, I could get a hands around that, but I'm not sure how we would do that. And it would be helpful to see some trend data to provide some guidance for us. I can go on that a bit more, but.
Yeah, I was going to say, Christine's had her hand up for a bit.
Sorry.
Thank you. Yeah, so I just wanted to mention, just as a practical matter, that it's not clear to me how payment would work in this situation, because the payment rules around Medicare Advantage are very complicated, obviously, but fundamentally, the payment that CMS makes, it is based on fee-for-service, the benchmark that comes from fee-for-service, right? So if you don't have fee-for-service, then I don't know how that payment is calculated. And then there are these other quality bonus payments, and there's risk adjustment that goes into it. So I think, I don't know, the state might then find themselves in the situation of having to maintain this very kind of complex, convoluted bidding process, which for one plan, it gets a little complicated. Now maybe you could further waive that or adjust that in some way, but it starts to go down a really kind of unprecedented path. And, I think a lot of people probably have the same reaction. Some of this kind of question is why, what would be the benefit of doing that? And is it even feasible?
Yeah.
So in just, if I'm hearing you correctly, Christine, one part of the additional analysis would be needed to determine whether this is viable or whether it would be beneficial is to look at how payment would be done for the state-run system. Would it be the same as it is under Medicare Advantage today, or is there a possibility that you could do it differently?
Right, yeah.
Okay, that's very helpful. Thank you. Eddie.
Hi, yeah, so I was thinking, so, Part A, Part B, or your Part C Advantage plan. And so this would be a state purchased plan, not a federally purchased plan. So the state would be the insurer. And so they would be contracting with MCOs for administrative services because they would be passed through the cost of the care. Is that kind of the mechanisms that would need to be in place? Because now the state would be responsible for those cares of those individuals, following the Medicare kind of system.
Well, I think you're right. I mean, the state would have to either contract out for those services, or it would have to perform those services itself through a new entity that doesn't exist today.
And this would be for the population to start of the uninsured, or is it supposed to be replacing those that are currently on Medicare?
This would be offered to people who are for people who are currently on Medicare.
Okay, so supplanting the federal government's system.
Supplanting or supplementing, depending. Someone made the point earlier that to make this mandatory would create even bigger problems. So I think we're talking about an option. Just as today, you can choose Medicare Advantage, a Medicare Advantage plan from any one of a number of insurers that offer. This would be the state-run option, analogous to Cascade Care Select, where again, that's an option that people have on the exchange to choose among other choices. But the goal would be to have it be attractive enough that it would appeal to a significant number of people. I think David had his hand up.
Yeah, thanks. I'm wrapping.
Yeah, thanks, Gary. I'm struggling to understand the question. So I work at a Medicare Advantage organization and I'm familiar with the bid process and risk adjustment, star rating and so forth. So if there were a situation where the state was precluded from creating a Medicare Advantage plan and essentially having a monopoly, where all state Medicare beneficiaries enrolled, the state would be in a competitive environment that is going to get more and more difficult to be profitable in with the new star rating and the new risk adjustment rules. So it would be interesting to talk through some of those details and more detail about how, what the state would need to do to make it a viable option.
I think that's exactly right. And whether it'd be worth it, as Christine has posed. Roger.
Yeah, thank you. So as I've tried to think about this, I've kind of gone down two paths. One is that somehow the state could say, well, we're going to contract with a health plan to be our plan, and somehow we could do better on the market than that plan would otherwise, which makes absolutely no sense. It's kind of a circular argument. To me, kind of another model has been what the state does today through it's for retirees through its UMP plan. And there's about 50,000 folks who are retirees in our state today that get health coverage through UMP. And just that's kind of an ASO model, if you will, where the state contracts with regions to be their ASO. They manage the system for them, but the state itself is at risk for those beneficiaries. So regions does not, carry the risk. And so I guess one could say, well, there's kind of a model out there today. I'm not advocating for it one way or the other, but it would be building on our existing UMP system. It's worth adding. And again, I don't have any trend factors, but I know the Healthcare Authority itself has posed some concerns about looking at more recent trends, per capita trends for UMP versus the plans it contracts with, particularly Kaiser, and UMP is struggling to keep up, at least for retirees. I mean, that says UMP per capita costs are going up higher. That's not saying that they're not strategies to be involved with it, but that is, I guess, my point in my story, another model that one can do some deliberations. I want to come up one more time, and I'll be quite honest. It would be helpful, maybe educational to the commission as much as us, if we could just see some per capita trend data. I know this isn't always easy to do over time. So we had a context of saying, well, look what's going on here. We may not be happy with the Medicare Advantage plans, but they're doing as well as the state is in its own purchasing on a per capita basis. I'll leave aside Medicaid. I know that one. And that being the case, you're kind of saying, well, why now would we want to enter into that when we're not necessarily going to be able to provide, equal, if not better, per capita growth rates? Because that's where we're going to get savings to expand, part of our benefit design. So that some of that information I think would be educational and helpful. Pam, I'm seeing you frown. I'm sorry to do this. Am I making sense at all?
No, you're making sense. I think what I'm just frowning at the complexity and the potential barriers to moving something like this forward. So, I think the commission's put something pretty problematic in front of us. But I see David's has, I'm saved because David has his hand up.
Gary, I thought that the California document, the memo, I don't know if you all provided that. I thought that was quite thorough. I don't remember if that left the window open for a state-based Medicare Advantage plan that had mandatory enrollment in it. Can you comment on what the determination was from the folks that wrote that memo?
I'd have to go back and look at it again, but I think what I'm hearing, and I want to move on to the next topic after Bob has his comment, but what I'm hearing is some additional information on how commercial Medicare Advantage rate setting and business currently is run, and some additional information on the UMP plan when we come back next would be helpful to focus us a little bit more on this topic. Bob?
Yeah, I just had a quick thought, and this is related to Medicare Advantage, but also maybe another topic that we want to talk about later, which is I've always thought that Medicare Advantage plans provide a very handy chassis for if the feds or the state, or maybe a state alone, could somehow pass state or federal legislation to allow the Medicare Advantage plans to enroll commercial enrollees, and then apply some of the same rules that are existing in Medicare Advantage, like there's a cap on out-of-network payments that really results in MA plans paying traditional Medicare prices, and which greatly enhances their cost containment capabilities. So I don't know whether Medicare Advantage plans could be used as a way of expanding coverage to the commercial population, and making use of their infrastructure that these plans have already developed, and then arming them with other additional capabilities like caps on out-of-network prices that would allow them to negotiate much lower in-network prices. Again, the whole point being to better manage care, but also to reduce costs. So that's a topic we can discuss later. It's probably more complicated than we can handle here, but something I thought I'd mention, given that we're talking about Medicare Advantage.
Okay, if we could go to the next slide. There was a lot of interest at the commission, at the last commission meeting, of the idea of essentially, at least for now, under the current legal environment that we're living in, leaving Medicare beneficiaries to the federal government, but making sure that they receive benefits equivalent to what others in the state's uniform financing system will receive. And again, similar to Vicki's description of what Jamestown has done, the tribe has made sure that everybody gets the same access to care and to benefits, regardless of what the source of the funding for their coverage and care is. So again, I think that the commission would be very interested in your thoughts on how this could be done, how it would be structured, how it could be funded, and what additional analysis would be needed to determine if it could be done in a cost-effective way and a feasible way. I see Roger's hand up.
As always.
We welcome your thoughts.
Yeah. Just a little bit of background for folks, and they may be aware of this. On this issue about wraparound benefits, state Medicaid programs do that today for, lack of better words, low-income Medicare beneficiaries. And they do that through something called the dual full benefit program. In our state, we have about 170,000 people that are these quote unquote full dual eligible. So they get not only what is covered by Medicare, but the full range of services that are provided by Medicaid, which I will say is probably the most comprehensive of any coverage there is in our country. So just as that we're kind of there a little bit as a step today, if you will. But that being said, it seems to me that in relation with the issue about wraparound services, we need some context of a, lack of better words, a benefit design we're kind of heading towards, because the question is, what services are you going to wrap around, right? And the notion there is, well, we have Medicare, and then we have our benefit design. And I know there's some of the usual things about, dental and vision, et cetera. But to really kind of wrestle with that issue takes us down another complicated pathway, and that is, do we have some vision about the benefit design we're trying to move towards, if I'm making sense? And then one last thing, if I might, because I saw somewhere, oh, I see it right there now, hearing and quote unquote long-term care. I would like to make a proposal for consideration for the future that we do not include long-term care in our discussions to date. And I would strongly encourage the commission to not use, incorporate long-term care services date. You know, Oregon looked at that thing, it scared them to death. We don't know how to do it anywhere. So they wisely said, we're going to set that away for a while. We need to build a system, and then over time, we can figure out how to finance it and get that in. And I guess I would encourage us to, for the time being, maybe make an acknowledgement of that, both with our work group and the commission. I think it'll be the death of all of us if we don't.
One comment I would make in response to that, Roger, is that in a number of places during the commission, or other times during the commission meetings, it's been noted that in terms of designing the benefit package, as you've mentioned, it's hard to take away things that people have today. So if you look at the various different benefit packages that exist in, you know, public employee, union plans, commercial plans, et cetera, there's a range. And the tension is between giving everybody something equal to the most generous, which is expensive, or alternatively, scaling it back, which means taking something away that people have now, or alternatively, continuing to have different benefits packages, which ends up eliminating a lot of the simplicity and equity that we're looking for in the system. So that's, you know, the commission's been struggling with that, and I think you've identified it as well as an issue that really needs to be thought through carefully. David?
Yeah, here I'm trying to think through how to be most helpful to answer the questions you have on the page, and I'm thinking that I would start by validating that there isn't already a Medicare supplement plan that covers these specific benefits, and I'm not particularly familiar with the supplements. But let's just say there isn't a supplement that covers dental, vision, long-term care. I think it'd be a fairly straightforward exercise to create a supplement lookalike plan. So you outline the benefits, go through the actuarial process of pricing them out, and come up with a cost. So I think your third bullet is probably the most difficult in terms of how might this be funded. And I think that probably goes back to the essence of the questions that the commission is dealing with in terms of, is it being funded out of new tax revenue? Is it being funded out of savings that are coming from consolidating state purchasing, et cetera?
Yeah.
David, can I push on you for a moment? And,
yes, right.
And again, it's around those supplements. I'm with you to a degree, but I'm struggling with, we're going to have wraparound services. We say that, and the question is, well, what are the services we're talking about? And I would challenge us. I'm just going back to when I'm about long-term care. I know it's an area the mayor's been involved with. When you start to bring in long-term care, it'll sink the ship. It will. And so my point is, well, that's okay. So we put that aside for more, just for the sake of our conversation. And I guess I would kind of ask of, or maybe the commission wants us to come back and say, well, you tell us what you want about, what you think is a reasonable set of wraparound services. But we need to kind of get our hands around, what needs to be in there before we, kind of go through the pricing out and looking at supplemental options, et cetera. One last thing I would say with respect to something, and I agree with the earlier conversation, John, about, contracting, benefits that folks have. I'm gonna just use the Medicaid program for a moment. In my mind, when we're talking about a universal healthcare system, in the near term, it's never going to have the scope of benefits, at least in our lifetime, that's covered by Medicaid. But there are ways we do that today in the Medicaid program where those additional services, I'm just again using long-term care, can be handled outside of if you will, the medical component or the medical and behavioral component. So I see people pondering.
I want to, maybe because Roger and I represent the same generation of health policy in Olympia, but when we did we had the original, Health Reform Act back in the 90s, we did pull out long-term care for exactly the reason that Roger said, that it would sink the ship. And we started with a benefits package, and then we did a per member per month on the benefit package. And then we started to, we pulled Medicare out, and we also pulled out the aged, blind, disabled, very high cost people because of the sinking the ship. Because what it would have done to the PMPM would have been, astronomical and beyond what the state could afford. So we do get ourselves in these circles, like what's covered, who's in, how are you financing? And it's hard to pull out, one thing at a time. So Medicare is a tough one to start with. I think people have done a really good job of kind of ferreting out some of the issues you wanted them to. And maybe we also need some, this will be an interesting dialogue back and forth with the commission about guidance from them and the kind of issues that we're raising.
Well, I mean, I think that's right. And I think that if the FTAC in presenting options, says to the commission, you need to think about the fact that including long-term care is going to sink the ship, that's something the commission, that's useful information. I mean, that, because there's obviously a tension between the dream of having everybody in and having everybody have the most expansive set of benefits possible, and then the question of what's feasible and what's affordable for the state to do. Roger, is that a new hand or an old hand?
That's a Roger hand. Gary, can I ask if maybe you and Pam a quick question? And it kind of came up as, in your opinion, does the commission, are they kind of in agreement with, I guess, what Oregon has concluded and the excellent memo, which I have a copy of, that California did, several years ago on the trials and tribulations of bringing Medicare into a unified health finance system? My question is the following: is that something that they acknowledge, or would they feel like they would like to have another review of these pathways? And if they do, which I hope they don't, I'd like to just throw out something for consideration later on. I think the folks in California in that memo that we kind of looked at did a great job. There's one other source, and this is, I'm giving them free advertising here for a moment, but in my former life, we did a lot of work with Covington and Berlin. Charles Miller, who's a senior partner there, dealing with Medicaid issues primarily, but also Medicare. I view him and that folks there are national experts. And so if we wanted somebody else to take a shot, they're not cheap, but to do a review of that, and that review, in my view, would be both, what the law says, and they really have a good feel for, the realities in Washington, D.C. of lending that perspective to the analysis. I guess we try to be clear about the game. If they need further, I don't know, feel like they've done due diligence with the issue that, no, we can't get to Medicare now, that would be another vehicle to reiterate, the work that others did, and from some folks that really have some, in my opinion, major national standing, if that would be needed.
So to answer the question, Roger, there has been discussion at the commission about if the decision is to explore every avenue of including Medicare beneficiaries, then it's likely that further legal support and actuarial support would be needed to present that recommendation to the legislature. And Angela can speak to this better than I, but I don't know that there's a budget today to do that. I think that's something that would need to be looked into and explored further. The commission has not yet made had a vote or made a determination to say, you know what, the problems with Medicare are so complex and difficult that for now we're going to decide to continue with the design of a uniform financing system in the state, leaving Medicare beneficiaries out of it for the time being. We're not quite at that point. And I think that's, the conversation that we're having now is part of the, what you all can help them towards making that decision. Obviously, it's not for us or even for you. I mean, it's ultimately the commission is going to have to make that decision, but the more understanding that they can have of the costs, benefits, challenges, et cetera, the better.
Yeah, I'm raising my real hand. I think it's a question of resources in pursuing a waiver on Medicare, but it's also a question of appetite and feasibility. You could put, if you could get a Medicare waiver and recapture all that funding and do something, then it makes some sense to pursue that. But I think the likelihood of succeeding and everything that's been shared with us is extremely low, and would sap resources away from things that we know are feasible and we know we could get done. So I think then it starts to boil down to kind of an equity question, which is that if you set Medicare aside, you potentially have a world in which the benefits of people in the universal state system are actually become better than the Medicare system in these wraparound benefits that you've identified. So I think if we could just kind of zero in on that question, which is how do we address the equity and benefits between people in Medicare and the universal system? How do we, maybe what's the big problem? How do we resolve that? Is that through a wraparound? And then two, how deeply does the commission want us to dive into the questions of how that'd be complicated to set up? It's probably feasible, but complicated.
And I think, I realize we're just about at the end of our meeting, but I would suggest that, and someone said this earlier, I think, if the state can demonstrate the ability to consolidate the state-run programs in a way that saves money and improves quality and equity and access, that would go a long way to demonstrating to whether it's the Congress or CMS or whomever, that there could be benefit to finding a mechanism that would allow everyone in Washington to benefit from that system.
Yeah.
Because there's a big chunk of the market that the state either controls directly or has regulatory authority over today.
Yeah.
Gary, I couldn't agree with you more. In my humble opinion, that would be the only way that Congress or CMS, they don't have the authority to do it, would be willing to grant us anything in that arena. So I want to re-stress that again. I think that's right on point. Can I add one other thing? Not to completely leave aside Medicare, but another recommendation back might be, I believe, hopefully if they enact it this session, Oregon is going to create their Universal Health Plan Governance Board. This is the board that's going to be charged with trying to go forward with implementing the Oregon system, and my point being is, should that legislation be enacted and that board is created, an encouragement that we work with them. I don't know how to structure that. We being, the commission, work with them actively, because we're going to be trying to kind of, in theory, go down the same path. And it'd be nice to be able to share some resources and knowledge, and, maybe two states making the case may carry a little bit more leverage than one. Then we can grab California, three of us can do it. But I would recommend that they give that some consideration. Thank you.
Roger, I have one comment to tell on that. I was at a conference this past week, and a former secretary of the VA talked about how he had wanted to implement telehealth and he was prevented from doing so because the calls would cross state lines and existing state laws didn't allow that. So he petitioned the president to use federal override authority that allowed him to do what he wanted to do and create a national telehealth system in the VA. And as we're talking here, it made me think that in an extreme scenario, if California, Oregon, and Washington all wanted to create a unified system, and any of you know the president, that might be one way to raise the idea of, if this federal authority that was used in the case of the VA is something that could potentially come into play if there are no other waiver options for Medicare at the state level.
Yeah, David, since it's 5, I'm gonna maybe table the idea. We could come back to that because we're gonna have to kind of grapple with what's going on in Oregon and California as well. One of the things I wanted to try to, if we could, I don't know if we can nail it down, but maybe just get a sense of the virtual room, is that I'm not hearing a lot of energy to pursue a waiver for Medicare. I'm hearing energy to think it through and figure out what to do, but I'm not hearing anyone would put their hand up to pursue a waiver or have significant questions that we should explore it more. So I'm just kind of asking really quickly if anyone wants to weigh in on that.
Pam, my only weigh in would be is, I think we're operating off the assumption, and what we've read, from other states, is we believe there is not a clear pathway today.
Yeah.
Things like 1115, et cetera, they're not there. But if there's a need to do due diligence to say, well, we've explored these pathways, and it's true that they're not absent congressional action, or as you say, the president, that may help say, okay, then, as you're pointing out, we're gonna put a portion of our discussion about Medicare, aside, and you just say maybe focus on, other equity steps around, wraparound strategies. I think that would. Now, I'm not being clear. I'm sorry. If we needed some more documentation to take Medicare off the table for the moment, I guess I would ask maybe if somebody could check with the commission to feel they needed that, and there are some resources that we can pursue to, to get that declaration. I believe some very high-powered sources, if you will. So I'm not helping, am I?
Yeah, I think we can go back to the commission with the sense of this conversation and ask what additional, on this particular topic, what additional help they think they need. So that's a helpful advice, I think.
Yeah, and we can have it as kind of a leaning, vague sense of the room, and maybe come back with maybe more of official documentation of it being an actual recommendation. I don't feel it as, we've had enough discussion to nail it as a recommendation, but I think we're kind of part of the way there.
Yeah. Thank you all.
Yeah, thank you. Thanks, Gary, for leading us through that really simple topic. We are a little bit over 5, so I want to respect your time and thank everyone for their participation. I thought the conversations today were fantastic. I wish we'd had more time in some ways but we will come back to both of these. If you have thoughts in the meantime, please feel free to reach out to me and Angela, and we can kind of incorporate that kind of going forward. We are going to revisit both of these big topics again, both the Medicare one, we need to kind of nail that down, and then to come back on the transitional ideas. Obviously, we got just really got a tantalizing distance into that topic, and we're going to have to spend more time on that next time. Anything else before they go to the order? Roger.
This is kind of a protocol question, because I'm kind of still fumbling around with Zoom. So when we're like the discussions we're having, obviously we want to keep moot, but should we keep our videos on so we see each other, or should we, if I'm not talking, I should hide my face, or?
During the conversation?
Yeah, just like we're having this last hour or so, should we?
I think most of people are keeping their videos on, which I appreciate. I like seeing people. It helps me, even though it's not like a real meeting. Even on Zoom, I can get a little bit about your expressions. So yeah, I think it's good. But I know that people need to manage themselves too, and I sort of trust people will know someone's at the door. One of your family members comes to the room. We all know how to manage those situations now.
Whatever. Thank you.
Okay. Thanks, everyone. And again, thanks for the staff for all the hard work, and to our wonderful consultants. And we'll be in communication with you in between meetings. Thanks all.
Thank you, ma'am. Appreciate it.